A very good day, my dear postgraduate students, after the cyclonic storm. I shall be dealing with not a very complex, but an untouched topic, the placenta, the grossing and its pathology. I would like you people to kindly take full advantage of all the subheadings and the pictures that are being shown. Think of the subheadings. The subheadings will take you to the answer. Wonderful words of Dr. Augustine Paul, my professor of dermatology. This incidentally is an enclosure giving you my details, to which if you can send your name and number, I shall be able to give you the link to the new WhatsApp channel, which easily carries the matter to you. Love is our true destiny. We do not find the meaning of life by ourselves alone. We find it with another. Perhaps this is in context with today's topic, the placenta. The Latin word means cake and the Greek word means slab, measuring about 22 centimeters in diameter, 2.5 centimeters in thickness, thanks to Wikipedia. Again, the enclosure giving the details. A series of pictures from Wikipedia which denotes the development of the placenta and its implantation. You find that after the fertilization, there are a lot of steps, but I shall not be going into all of them, except perhaps these. So I find that the zona after hatching gets implanted in the uterine epithelium. And there is the differentiation into three zones, namely the epiblast, hypoblast, and the trophoblast. There is a bilaminar disc and two cavities which are developing, after which we are all quite familiar. This one is called the primitive streak, which is probably vital in the embryogenesis. There is the development of the amniotic sac and the yolk sac, the mesoderm. Finally, you find that these are all getting implanted into the host decidua or the mother. And there is what we call the fetus that is developing, and strangely, this is the umbilical cord. Now, this is a wonderful picture of the chorionic plate and the villous. An umbilical cord is shown over here, and this is a chorionic plate, which is nothing but the spiral accumulation of the major blood vessels. The cord itself carries two arteries and one vein. Strangely, you find that the artery will be carrying the deoxygenated blood and the veins the oxygenated blood. As the arteries enter, they branch and again rebranch to form the primary and the secondary villi. The venous blood from the mother, on the other hand, will be carrying oxygenated blood into the villus, which in turn is being carried to the fetus. And these are the key words which I would like you people to kindly decipher. A beautiful picture over here, the chorionic plate, and I find that there are the major blood vessels which are branching and rebranching, both the arteries and the veins. And there is also a strip of capillaries which interconnect them. Look at this. You find that the vein is colored as red and the artery as blue. Oxygenated and deoxygenated. Very important. Every picture matters. This is a cross section that is showing the cytotrophoblast, the syncytial trophoblast, the pale green over here, which may be forming the syncytial nodes. Apart from that, there can be the Hofbauer cells, and then there can be the capillaries with the endothelium. So I would like you people to understand the major function can be nutrition and oxygen, fetal and maternal circulation, metabolites to be excreted, and endocrine function also. And the three major components will be the fetal membrane, placental disc, and the umbilical cord. References. This is again an important one regarding the implantation. Initially, there is and orientation. It gets arranged, of which one will be the blastocyst, two is the embryoblast, and three is the trophoblast that you people see. This progressively comes closer and gets opposed to the decidual membrane. Finally, it gets adhered to, and then there is an invasion or a penetration. Finally, 7, I find that there can be extravillous trophoblast which reinforce the implantation into the mother. Now, what are the placental abnormalities? These can be, this is a normal placenta that we see. It is almost at the cardia or the uterus. Sometimes it can be a little low lying. This is also considered to be normal. But placenta previa, where it comes in front of the fetus, and placenta accreta, where it gets somewhat glued to the membrane, and increta is it increases its penetration, and percreta is maybe through and through, which is an undesirable addition. So these are some of the placental abnormalities we shall have in mind. We are not obstetricians. This is again a color to the one. So I find that there is the umbilical cord, there is the red color is the vein, and the blue color is the artery over here. These are the branches, and ultimately I find that there is the blood that is getting transferred. And ultimately I find that the venous blood is over here, and it is carrying, this red one is going towards the fetus. It is carrying the oxygenated blood. And along with the supporting cells in the stroma, the entire structure is called the villous. And this pink color will be the decidua that I am seeing, and this is the endometrium here. This is again a beautiful line diagram showing the twisted artery and vein. Look at the colors and understand. Blue color is the artery and red color is the vein because of the deoxygenated and the oxygenated blood. They branch. Primary, secondary, and tertiary branches are there, and they are finally interconnected by means of capillaries. At a cross section, there will be the cytotrophoblast, the blue color, and the pale green color, the syncytiotrophoblast, where there can be syncytial knots. There are also some cells called the Hoffer cells, probably some kind of macrophages which are there. And these are all the cut surface of the fine capillaries that are there. Science direct. Placenta by means of its shape. It can be diffuse. So I find that it is totally through and through covered, or it can be multicotyledonary, wherein there will be multiple nodules that are seen over the surface. Zonary, wherein only part of it is being covered, and discoid, wherein the entire placenta is being covered by it. So this is important that we people have an idea of, because during grossing, the site of attachment matters. Review article, Frontlines Physiology. And this again is a reinforcement of the original pictures. And look at the various, the yolk sac, the heart is getting formed, and this is the fetus as such, the chorion, and the blood vessels, the cord. Monograms are books that deal about a single subject, and I always have a great reverence to Harold Fox. And this is another one, Keep, the placenta, the structure and function, the pathology. And this is Harold Fox from Baltimore. So he has done a superb work on the placenta alone, and one such thing is the aging of the placenta. This is hand-drawn diagram of the blood vessels. Again, the reference which you will have to send your name and number to. Now, this is the full term placenta that I am seeing. When I say placenta, I would like you people to kindly appreciate the umbilical cord. It is more or less central or slightly eccentric. And then there are the branching and the rebranching blood vessels going up to the periphery, radiating blood vessels. And this is obviously the fetal surface because the cord is over there. The other one will be the maternal surface, wherein there will be a lot of these nodules, and they are called as cotyledons. And they are reddish brown in color. They are nothing but the entire parenchyma of nodules which are there at the maternal surface. The membrane has been removed so as to display this. So this is the number I would like you people to go through. You find that there will be the 40 about major villi will be there and they are perpendicular to the chorionic plate. It will be containing arteries, veins, fibrostoma and capillaries. And there will be the secondary villi and all of them are parallel to the chorionic plate. Finally, there is a tertiary villi around which there will be the placental lobules and the basal plate. They evolve during pregnancy and become immature during early pregnancy and finally they mature in the third pregnancy. This is a picture of the first trimester wherein I'm finding that there is more or less fibrosis, not much of vascularity is seen, but then there is some amount of cytotrophoblast that should be made out. Whereas during the second trimester, one thing that becomes very striking is the proliferation of the blood vessels and the development of the syncytial knots over here. And during the third trimester, it is highly vascular because it has to support the growing fetus. At the same time, there will be a fibrostoma to support it, which will be made up of the something similar to the Wharton's jelly that you see in the umbilical cord. Now, one of the pathologies as such. On the left, there is again a structure with a villous or a pair of villus. Whereas here I am finding numerous. I would like you people to kindly count them. They are of the same magnification. This is almost blown up and as though there is a lot of water that has entered it and it is a grape-like or a Hydatidiform. There may be a lack of vasculature. It will be covered, of course, by the cytotrophoblast and the syncytiotrophoblasts. One definite method of diagnosis will be when you keep it under the microscope, a single villus may be occupying a huge space, which is unlikely in a case of a normal. Now, dear students, what shall we do when we examine the cord? Usually, we do not pay much attention to it. But see what is happening over here. A cord can be hypercoiled, like a screw, or it can be hypocoiled. Less number of coils will be there. Number of vessels can also vary. It can be 2 or 3. And multiple cut surfaces will be needed for us to express the abnormality. Hematoma, cysts, and thrombi will be seen. Surface nodules and true or false knots are not uncommon. Plaques in the form of Candida funicitis. It is a fungus that is there. Look at this picture over here. It is a Candida funicitis and the entire fetus is being affected by it. Incidentally, my name is over it. I am not the author of it. We will have to remove the cord from the placenta as close to its point of incision as possible for a thorough examination. And this is the candidiasis or funicitis that is there. The umbilical cord. Normally, you find that there are 3 vessels from the umbilical cord. They enter the fetal cavity. This is supposed to be the fetal body as such. And you find that there will be an umbilical artery and there will be going to the number 1 to each side of the bladder as such. And then there will be another branch which goes to the ductus venosus, which may become impatent later on. So here are the 2 arteries and then a vein over here which is being supported by Wharton's jelly. Sometimes, as I told you, there can be a single artery and a vein. These things will not affect the fetus, but then making a note of it is important because the fetus can be having congenital anomalies elsewhere and that is supposed to be followed up. And there is an increased amount of spirals over here. In some regions, it is thin. And here again, it can be because of the paucity of the Wharton's jelly. It is reduced. So the grossing will be required at these sites. A precious lifeline that began in my primal mother and has come down to me. What are the abnormalities? As I told you, there can be thickening and thinning. So there are thick areas, there are thin areas as well. The number of spirals, look at this and this as well as this. And this is because of the diminution in the Wharton's jelly acid. There can be a true knot, just like a knot that you people tie. This is a hematoma that I am able to make out, or a hemangioma. These are some abnormalities that we'll have to study and make out. Moreover, the length of it also can vary. I'll be showing it elsewhere. It is the mode of entry. Normally, you find it is quite one entering as a single vessel. But then here the branching occurs even before entry into the placenta. And that is called a Furcate cord. This is a beautiful diagram by this author over here from the Australasian Society for Ultrasound. Ultrasound, it plays a vital role in making the diagnosis. So a collaboration and a correlation with them will be mandatory. It is normal over here and here it is Furcate. Cord round the neck, all of us know the distress it causes. It can be because of the long cord, as long as 70 centimeters. Obviously, there is a chance of a cord round the neck. What we will have to look for will also be the Apgar score when we get the placenta. And what is the mode of delivery? What are the other abnormalities or difficulties that they were having? So, this is a case of twin boys at a gestational age. Each twin is found within his own amniotic cavity. But in this case, I find that there are the two cavities over here, but then they are fused together by a single dividing membrane, which you people are seeing here. In this case, it is becoming more discoid in shape, where here it is more spherical or circular in outline. So this I can call as diamniotic and dichorion. As a result of which, in such cases, when you people study, normally when I get a membrane, the membrane will be a single flat one, just like any ovarian cyst. But in this case, I'm finding a membrane, again I'm finding another membrane, each of which is being lined by its own series of cells. So there are the two membranes which can be made out and they will have to be studied. In this case, I find in the case of a twin pregnancy, there are two cords which are sharing the same circulation and they are entering the fetal surface of the placenta. Sometimes it does happen that when there is a twin, you find that one of them can develop where the other might not. And in some other cases, when there is going to be an abnormality, the fetus itself can be macerated. You are supposed to measure the length you will have to detach the segments, as I told you, as close to the placenta as possible. Sometimes it can be very long. You will have to find out the average diameters where the areas of thickening or thinning are there, and the periphery should be about 3 centimeters less, means it is marginal. That is when it is close to the periphery, and more than 0.5 centimeter is supposed to be marginal. Velamentous or Furcate. Furcate I have already told you. Sometimes there can be amniotic webs which are being formed. This is a normal cord over here, and look at the cord, it is getting inserted into the placenta at a normal one. Sometimes velamentous, it goes round and then it attaches by the side, an abnormal insertion. And this is again velamentous in a case of a placenta previa. What will be mandatory for us is the clinical history, which we normally or never get. So that is where the problem arises. There has to be a thorough knowledge of the clinical history and a speedy request form which contains the EMR system. What is the EMR system? Electronic medical records. When the clinician wants everything, they want all the details from the laboratory in one stroke, whereas they do not provide us. As a result of which you find that we are unable to get all the details. It might be a little bit of a burden on the nurse, clinician, and the pathologist, which is all reduced by means of this EMR system. For example, the gestational age at delivery. What are the maternal details, gravida, para, and whether there was any preeclampsia, diabetes, etc. And this is a velamentous one. I find that Even before entry, there is a branching over here, and then it is being supported by means of this membrane. This membrane appears to have extended over here, but the strange thing is there is no Wharton's chain. A placental web. Look at this one, beautiful picture from web pathology. So here I am finding that there is a branching and then there is a membrane even before entry into the placenta. Again, the details that are essential will be what will be the labor course, PROM, for example, premature rupture of the membranes, vaginal bleeding, what is the fetal heart rate, weight, APGAR, any other additional details, and so on. The beauty of motherhood is not in reproduction, but in inclusion to experience another life as part of it. This is what I told you. Wherever it's possible, there is a series of details which is available. There can be a patient whatsoever, what is the date, etc. All are being electronically fed into. And when you people go into the details, you are able to get, just like they get the detail of the hemoglobin, total count, platelet, or the blood sugar, urea, cholesterol, etc. Here again it is possible. What is the lipid panel? What are the other things? What are the culture details? What is the CBC over here, etc. All could be found. Regarding the grossing, it is always preferred that a fresh specimen is given. Fresh is supposed to be the best. It can be compared to formalin fixed, which is also okay. And I was taken aback by this statement. A placenta can be preserved in the refrigerator for a period of at least 1 week, as long as 1 week. And this is the Amsterdam consensus. The reference is given over here. You people can go into. This is my reference for your joining the RATS WhatsApp channel. Again, whenever you get the placenta, whether it is a singleton or it is a multiple one, and then you'll have to identify the surfaces, the cord, the clot, etc. from the container itself. And you'll have to weigh each of them, measure each of them, the fetal surface, maternal surface, membranes, etc. Sometimes you find that there can be a disruption or a rupture of the membranes, so wherein you are supposed to take the bit at the junction of the normal and the ruptured site. Of course, the other things are there. Look at the types of the placenta. Here it is a membranous placenta. And there is a normal placenta over here, which is getting attached only to one part of it. Here it is membranaceous, wherein it encircles the entire placenta as such. Sometimes the placenta can be having an accessory loop. Circummarginatus, it goes beyond the plate and then it circumvents the whole thing. And circumvallate means therein, before the entry, you find that there is a pull that is possible. Bilobe placenta, when there are two placentas of or two lobes of almost the same size, whereas this is accessory. And velamentous is out of place. So this is the development that is over here. I'm talking about the story of the twins. So there can be something called as dichorionic and diamniotic, or it can be monochorionic and diamniotic. In the sense, there is not a clear dividing line that is possible. And monochorionic, monoamniotic is both are within the same amniotic sac. Conjoined twins when they are fused together. The same thing is very clearly explained over here. Monochorionic and monoamniotic, two within one cavity. There is a separate cord for each. And monochorionic diamniotic, there is a membrane that is dividing a separate cavity for each. And dichorionic diamniotic is a clear divider and two cords. Dichorionic diamniotic is two amniotic sacs are over there, and there is absolutely no relation here. Extraplacental membranes, circumvallate. So here it circumscribes almost the entire placenta, the membrane, as a result of which there is very little permeation and the survival is remote. There is a completeness of the membrane. You will have to identify the rupture, color, opacity, the site of entry, and the type of the placenta, velamentous insertion, etc. And this incidentally are the layers. This is the entire placenta over here. You find there will be the epithelial cells, the basement membrane, fibroblast. This is the amnion over. This is the chorionic villi. This is the deciduum or the maternal surface, obviously. So as I told you, this is probably the basement membrane of the chorionic plate over here. There will be the fibroblast which will be supporting, and I'm finding the reticular layer. Lower down there is the basement membrane again. The trophoblastic cells are seen in this towards the maternal region wherein they get implanted. Normally you find that the placenta is translucent. You can see through it. It can be green stained because of the meconium, brown stained because of hemocytin and hemorrhage, opaque because of inflammation, chorioamnionitis. The same thing is given. I would like you people to kindly by heart all these things. The chorioamnionitis, there is a phenicitis, amnion nodosum, chorangioma, chronic abruption. Because of hemorrhage, there can be brown color. Infarct, then the fibrin deposition, meconium staining. So this is a gross description. I would like you people to go through. I am not reading it again. The maternal surface, always there should be a checklist. You find that a checklist is always essential. Determine the maternal surface, whether all the cotyledon surface, that should be a minimal number. And are they disrupted or complete? Disrupted and incomplete means there is some tissue that can be missing. What is the junction? Whether it is intact or disrupted. Fragmentation from the remaining placenta. Whether there is any retroplacental clot. Whether it is central or peripheral. Compression of the underlying tissues. Areas of thinning and atrophy. And you are supposed to palpate the firm and the soft areas. Let the fingers do the walking. That's what he says. Serial sections at 5 millimeters. I would prefer at least 2 centimeters. Color. And the pale region will be avascular. Lesions, the number of lesions that are present. For example, number of infarcts and the surface it covers. Color, consistency, percentage of Villous. Again, looking at the surface, I am finding multiple nodular areas. There are some somewhat bile-stained regions over here, some pale areas, amnion nodules. Courtesy Sanjita Revision for this wonderful reference. Outlines in pathology. This is the story of the membranes. Now, how do I remove it? We are just cutting a rectangular strip and then we are giving it. But what is actually to be done is, this is a forceps over here. It is caught and then it is rotated on itself or rolled over. See what is happening over here. And finally, the unwanted or the unequal regions are cut off. And a bit can be given from the more regular area so that when you embed it, you get the complete surface. Some books say you can use a probe or you can use a fine forceps, which is not used. And when you do all this, so there is a roll, trimming of the edges, cutting to size, and it is like a jelly roll that you people do it. If you are having some difficulty during the processing, one end of it can be pinned so as to facilitate embedding. This is again the story of the membranes. There's a cord over here and then the membrane. See how they are being circularly or rectangularly cutting it, and then it is being rotated around in the form of a roll or a jelly roll, as it is said. It is again cut and it is being embedded. As a result of which, when they cut the section, this is exactly what you people get. The advantage is multiple regions can be studied under one field. In this case, there is a dividing membrane, and here again the process is not different. They give a bit from this region as well as from the dividing membrane, and then the full thickness of the placenta is being studied. And obviously, each of the cord will have to be sampled. The regions of infarct. It can be a solitary infarct, and when it is less than 1/3 of the fetus is not affected by it. That is what the web path says. But sometimes it can be multiple, obviously resulting in a fetal death. A nodule is present over here, And so maybe another one also. This is a chorangioma. Chorangioma is nothing but a hemangioma that you people see. It is well circumscribed. Even in your general pathology, the hemangioma is well circumscribed but not capsulated. The fetal capillaries will be proliferating. Around that, there can be the stroma and the trophoblast. Some amount of degeneration, infarction can all be seen. But then, you'll have to look for any atypical chorangioma, but malignancy is unlikely. Chorangiosis. So this is one thing of the chorangioma. The blood vessels are all back-to-back in arrangement, and there is a plump endothelial cell, the supporting stroma that you people see, fairly uniform. Chorangiosis is also proliferating, but here I do not find the stroma here, and they are all obviously villi with increased amount of vasculature, and this has to be distinguished from this. This is our friend, the choriocarcinoma. One of the sites of the choriocarcinoma can be the placenta, though it can occur in the testis or in the mediastinum or in the ovary or else. And there will be the two types of cells. The clear cells will be the cytotrophoblast, and the pink multinucleated cells will be the syncytiotrophoblast. And obviously, my professor used to say there will be absence of villi. Fibrin deposition, areas of necrosis is abundant. And it is like a bunch of grapes. In fact, the lady will be giving a history of passing grapes in the uterus. This is what you people see. This is yet another picture. This is a decidua over here, and you find that it is getting implanted. There is a syncytiotrophoblast, the cytotrophoblast. Within these, however, there is no villi. Look at the pleomorphism, angry-looking areas of hemorrhage and necrosis. And the choriocarcinoma, as I told you, you find the radiologist will be preceding us in the diagnosis. That is what they have done over here. The placental shapes can be discoid. They are flattened. It can be oval or triangular. It can be duple, bilobe, bipartite or tripartite. And it can be bidiscoidal or tridiscoidal. And succenturate wherein there will be an accessory lobe, which is smaller. The membrane insertions we'll have to make, whether it is at the normal one or circummarginate. They go beyond the margin and then they get inserted. Circumvallate membranes insert along the edge and then fold back. A double layer of amnion, chorion, necrotic villi, etc. will be rising out of this. So this is the examination of it. You will have to look for the transparency, the vessels, and the mode of insertion, etc. As I told you, the velamentous cord we have already shown. Latin means it's a cover or screening. The normal one that you people see. And look at the web path that is giving us the abnormal one. Here I am finding only a couple of blood vessels. Here there is maybe one is underdeveloped, one other. So just to give the multiple pictures that are possible. And the supporting water and jelly is very beautifully brought out from them, thanks to web pathology and research care. A true knot. Obviously, there would have been hypoxia and fetal distress. And this again has been removed. It strangely looks a little dangerous. This has been found to be a hematoma, and there is no aneurysm or a rupture that is over here, and the fetus is hale and healthy as per research care. The bits, as I told you, you'll have to examine the various surfaces, you'll have to trim and then measure the cord, etc., remove the cord at multiple levels, examine the cord for the blood vessels, the mode of insertion and the division that is over here, wherein the dividing membrane will also have to be sampled as well as the cords independently. Check for any blood clot and hematoma, and the placenta should be weighed. These also are included. The membrane, of course, the cord is removed as close to the placenta as possible. If there is some amount of fats processor is also appropriate. So this is one that I'm not going to go into. Again, the placenta and its cord and the membranes. The nodules over here, they can be the amnion nodosum, vernix granulosum, and chorion nodosum. Sometimes a squamous metaplasia is also indicated in the membrane. This is the electron microscopic villi of the microscopic picture of the villi over here. The cytotrophoblasts and sessiotrophoblasts, they can be made out, and sometimes microscopically I can see the mitotic figures. Now this picture is for us to see the nodules that are present. I am finding multiple white nodules over here, and the nodules can be amnion nodosa or vernix granuloma. Sometimes there can be chorion nodosa and squamous metaplasia. Microscopically, squamous cells can be seen over here. These will have to be looked for and sampled. And this is the electron microscopic picture of the villi as such, covered by cytotrophoblast and the syncytotrophoblast. So this is it. And when you go into the further microscopy of it, mitotic figures can be made out. This is the superficial picture or the scanning electron microscope that is there. The placenta, what is the general anatomy? Again, a beautiful picture thanks to pathology outlines. So there is some area of the fibrin over here, the stem villi. And then there is a primary, secondary, and the tertiary villi. I find multiple of them are there. Probably if there is too much proliferation of the capillaries, the term chorangiosis can be used. Not only are all these important, but sometimes lipid profile also. I was taken aback that lipid profile can be studied in the placenta. I do not know much about it, but then it is knowledge to me, so also to you. These are the things that we have covered so far, and these also. So I would like you people to kindly go through and look at the pictures in leisure. They are worth their weight in gold. Thank you.